Hello everyone, welcome back to our channel. With the next topic in the lower limb, the knee joint. I'm happy to meet you all. The knee joint is an important essay in the lower limb, and it is the large essay to write also. So the knee joint we will see in this video. Those who have not subscribed to the channel, do subscribe now. Keep watching the videos. We will move on to the topic. Knee joint, otherwise called as genual joint. It is the largest joint of the body. The hip joint is the next largest joint, and the knee joint is the largest joint of the body. So we will see the knee joint under the following headings. Type of the joint first. Any joint we have to tell type of the joint in the beginning. So what is this type of the joint? Compound and complex synovial joint. Do you know what is compound and complex? In the general anatomy you should have read compound means involving more than two articular surfaces. Complex synovial joint is if the joint cavity is divided by the partition into compartments, like menisci dividing the joint into compartments, then it is called complex. So this is the compound and complex synovial joint. Why it is compound? It involves femoropatellar articulation, tibiofemoral articulation. So more than two articular surfaces. What is the type of knee joint between the femoral condyles and the articular surface of the patella is the sellar type. And between the tibial condyles and between the femoral condyles is the condylar type. That is, structurally it is compound and complex, functionally it is modified hinge joint. So elbow joint, if you compare the knee joint with the elbow joint is the hinge joint, knee joint is functionally modified hinge joint. Why? Because there is two reasons. Transverse axis of the movement in the knee joint is not fixed, and there is conjunct rotation of femur or tibia around a more or less vertical axis. That's why it is called as modified hinge joint. Now we will see the articular surfaces. Articular surfaces proximally condyles of the femur, distally the condyles of the tibia, in front posterior articular surface of patella. So now we will see the articular surfaces. So these are the femoral articular surfaces of condyles of femur. These are the tibial condyles, upper surface of tibial condyles. If you see this in the condyles of femur, front, lower and also posterior surfaces of femoral condyles. Here upper surface of tibial condyles. And this is the posterior articular surface of patella. If you see the posterior surface of the patella, it will have this division into 6 parts. Upper 1, 1, 2, 3, 3, 6 parts. And also this side in this medially, that is the 4th part. So what are these are? These are the articular surfaces in various movements of the knee joints. So these are the various parts of the patellar articular surface articulating with the femoral condyles in various movements of the knee joint. So this patella, you should have learnt all this in the posterior surface of the patella. So we have completed the type of the knee joint, articular surfaces of the knee joint, ligaments of the knee joint. Ligaments of the knee joint are 10, or including the capsule and synovial membrane, they are 11 in number. So this ligaments of knee joint we can divide into, it is outside, what are the ligaments outside the knee joint? what are the ligaments inside the knee joint, that is out extracapsular and intracapsular. So we will see this capsular ligament and synovial membrane. If you see in front, ligamentum patallae, on the sides tibial and fibular collateral ligaments, behind oblique popliteal and arcuate ligaments. So these are the extracapsular. Intracapsular, anterior and posterior cruciate ligaments, medial and lateral menisci, and then coronary ligaments, transverse ligament, meniscofemoral ligament. So these are the intracapsular. So intracapsular structures of knee joint may be short notes. Capsular ligament, upper attachment posteriorly to the upper margin of the intercondylar notch, medially to the medial surface of the condyle, laterally to the lateral surface of the lateral condyle. Anteriorly it is deficient. So this is the capsular attachment of the, so these are the capsular attachment of the knee joint. In anteriorly it is deficient. On the sides they are attached to the condyles and posteriorly to the intercondylar notch. Lower attachment to the posterior margin of the intercondylar area of the tibia and behind the lateral condyle, deficient for the passage of the tendon of popliteus. In front, attached to the two sides of the triangular surface of tibia. Synovial membrane, if you see, it lines the inner surface of the capsule and the portion of the bones within the capsule. Traced above, it is continuous with the suprapatellar bursa in front and a triangular fold of synovial membrane. The infrapatellar fold extends between the femoropatellar and both condylar parts of the knee joint. The lateral margins of the fold are free and form the alar folds. So these are the alar folds. So these are the synovial membrane and the margins are called as alar folds. The semilunar interval between the alar folds communicate. So these are the semilunar interval between these folds. Communicate the femoropatellar compartment with each condylar part of the knee joint. So we will start with the ligament in front. If you see, interestingly, one ligament in front, one ligament on medial side, one ligament on lateral side, and one ligament behind. So these ligaments first we will finish. Ligamentum patallae. So this is the ligamentum patallae derived from the tendon of quadriceps femoris. So you should have learnt that in the newborn this quadriceps femoris is attached to the upper, it is attached to the upper surface of the tibial condyle. Then this patella is formed in this tendon of quadriceps at around 3 years of age. So this ligament is now called as the ligamentum patallae. Extends from the apex of the patella to the upper part of the tibial tuberosity. Tibial collateral ligament on the medial side. So it is called medial ligament. It represents the detached tendon of what muscle? This tibial collateral ligament represents the detached tendon of one muscle, that is the degenerated tendon of adductor magnus muscle. So in the morphologically this adductor magnus has extended up to the tibia, then it has now taken its insertion in the adductor tubercle of femur. The ligament consists of superficial and deep parts. So both parts are attached above to the medial epicondyle of femur. Below, we will see the picture. So this is the tibial collateral ligament. Both parts are attached above to the medial epicondyle. Below the superficial part extends down to the upper part of the medial border of the shaft of the tibia, where these three muscles are inserted. You should have learned they are called as the guy ropes, gracilis, semitendinosus and sartorius. In between these muscles only pes anserinus bursa is present. Deep part, so the deep part is attached to the medial condyle of the tibia. So this is the deep part attached to the medial condyle of the tibia. So fibular collateral ligament is present on which side? Lateral side. So it is called as the lateral collateral ligament. It represents the detached part of the degenerated tendon of peroneus longus muscle. So it is more thicker than the fibular collateral ligament. It extends as a fibrous cord downward and backward, same from this side lateral epicondyle of femur to the head of the fibula, close to its styloid process. But difference between the tibial collateral and fibular collateral is it is not adherent to the fibrous capsule. So now we will see the attachment. So it is like this. From the lateral epicondyle to the head of the fibula, close to the styloid process. So we can see it is how it is thicker, cord-like, extending from the lateral epicondyle to the head of fibula, and it is not adherent to the fibrous capsule. Gap between the capsule and the ligament is occupied by the tendon of popliteals and inferior lateral genicular vessels and nerves. Crossed superficially by, so this is the crossed superficially. What tendon? Biceps femoris. So oblique popliteal ligament is behind. So derived from tendon of, so I have told derived from this tibial collateral ligament and fibular collateral ligament derived from the muscles. Now this oblique popliteal ligament is expansion from the tendon of semimembranosus. So all these are the PG MCQs for you. From the posterior surface of medial condyle of the tibia to the lateral part of the intercondylar line of femur. So it is pierced by middle genicular vessels, nerves, and the terminal part of the posterior division of obturator nerve. Arcuate ligament, it is also extracapsular. It is Y-shaped. It is derived from the posterior expansion of short lateral ligament. It extends backward from the head of fibula. So stem is attached to the head of the fibula. Anterior band and posterior band. So anterior band and posterior, one is attached to the condyle of femur and another is attached to the condyle of tibia. Cruciate ligaments. So now start the intracapsular ligaments of the knee joint. So first is cruciate ligaments. They are intracapsular but extra synovial. They are named, why they are called as cruciate? They resemble the cross structure. How they are named as anterior and posterior? According to their tibial attachment. So if you see the cruciate ligament anterior, it will be front in the tibial attachment, but see the femoral attachment, it will be posterior. So both these cruciate ligaments are developed from the posterior part of the intercondylar septum. In the embryological life, they are represented by intercondylar septum, but only present in the adult as the cruciate ligaments. Anterior cruciate ligament. So these are the intercondylar area. Attachments of the structures in the intercondylar area. You will be asked, this is tibial condyles. In between that is the intercondylar area. What are the attachments in the intercondylar area? Attached below to the, so that is the, this is anterior cruciate ligament. Below to the anterior part of the intercondylar area of tibia, in between the anterior horns of medial and the lateral meniscus. So this is the anterior horn of lateral meniscus, anterior horn of medial meniscus, and this is the anterior cruciate. So in this intercondylar area, the structures will be represented as M, that is medial meniscus, A, anterior cruciate ligament, L, anterior horn of lateral meniscus. So MAL. In the posterior part, it will be represented as LMP. So this is L, that is the posterior horn of lateral meniscus. M is posterior horn of medial meniscus, and this is the posterior cruciate ligament. That's the way to remember the structures in the intercondylar area of tibia. So if you see the anterior cruciate ligament, how it is attached to the femur, it is attached to the posterior part of the medial surface of lateral condyle of femur. So it will be posterior. In the lower attachment, it is anterior. In the upper attachment, it is posterior. So now you can see the anterior cruciate ligament in this. So it is attached to the posterior surface of the lateral condyle, medial surface of posterior part of the medial surface of the lateral condyle of femur. And this is the anterior cruciate ligament. So sorry, this is the posterior cruciate ligament, and this is the anterior cruciate ligament. So now you can understand how important this cruciate ligament. They are not simply in between the knee joint. They are the ligaments which bind the bones. Very important ligaments to hold the knee joint in stable position. Posterior cruciate ligament, we have seen already in the intercondylar area of the tibia. Posterior part of the intercondylar area of the tibia, behind the posterior horns of medial meniscus and lateral meniscus. That's what I told as LMP. Above it is attached to the medial condyle, lateral surface of medial condyle, but it is anterior part. So now you should have understood. It is in the posterior in the tibial attachment, anterior in the femoral attachment. Menisci. What are menisci? They are the fibrocartilaginous disc-like structures, semilunar in shape, presents anterior horn, posterior horns. They are the two ends, two surfaces, upper and lower surfaces, two margins, medial and lateral margins. Now you can understand. This is two ends, anterior horn, posterior horn. This is upper surface, and this is the medial margin, and this is the lateral margin. Horns we have already covered. They are attached to the intercondylar area of the tibia, MAL and LMP. Functions. Why this? This because of the presence of menisci only, the knee joint is called as the complex type of joint. Functions: increase the concavity of the condyles, because you can compare the femoral condyles and tibial condyles. How much difference femoral condyles, how they are convex, and tibial condyles, how they are shallow. So this menisci increase the concavity of the condyles, maintain potential joint space for flushing of synovial fluid, shock absorber, help the complex mechanism of gliding and angular movements. Meniscofemoral ligament, posterior horn of lateral meniscus, gives attachment to this meniscofemoral ligament. Anterior and posterior meniscofemoral ligaments. Anterior is called as ligament of Humphrey, posterior is called as ligament of Risberg. They regulate the forward movement of the lateral meniscus during the movements of the knee joint. So these are the meniscofemoral ligament. posterior meniscofemoral ligament. So this is the posterior meniscofemoral ligament attached to the lateral meniscus. Now we are going to complete this ligaments. Transverse ligament, they connect the anterior horns of both menisci, medial and lateral menisci. So this is the transverse ligament connecting the two anterior horns. Coronary ligament, they are the parts of the fibrous capsule. They are attached to this margins of the menisci. They will be called as, so parts of this attachment to the menisci will be called as the coronary ligament. So we have completed this ligaments in detail, extracapsular and intracapsular. So in this, if the knee joint is asked as essay, you should be able to see the divisions of the marks and you have to present how much marks are given to ligaments and how you can complete the total essay in the time. Now movements of the knee joint. Flexion and extension, medial rotation and lateral rotation. That's why we called this knee joint as the modified hinge joint. If it is pure knee joint, this medial rotation and lateral rotation will not be there, but there is medial rotation and lateral rotation in the knee joint, so that's why we are calling this as the modified hinge joint. So range of extension and range of flexion. Flexion, you can flex still the posterior surfaces of the thigh and the knee, thigh and the leg oppose. Extension, bringing this flexed knee to the normal anatomical position. Rotations may be conjunct or adjunct. So flexion and extension take place around the transverse axis. During the last 30 degree of extension, if you extend, you can try to completely extend the knee joint as if like locking the knee joint. In that position, in the last 30 degrees, medial rotation of femur occurs. Then when you try to flex, in the beginning of flexion, lateral rotation of femur occur. They are called as the locking and the unlocking. So if you try to tightly hold the knee joint, that is called locking. So in that position, along with extension, there is a medial rotation of femur, that is called locking, and lateral rotation of femur during the initial stage of flexion, that is called unlocking. Rotations take place around a vertical axis. They are conjunct and adjunct. Conjunct means that happen in the initial stages of flexion and last stages of extension. Mechanics of knee joint, that's what we called this as locking mechanism. Completion of last 30 degree of extension is called as locking mechanism or the screw home movement. So in this, the lateral condyle serves as an axis, lateral condyle of femur, whereas the medial condyle rotates backwards. So that is the locking mechanism. Muscles producing movements, we will see. So if you see the locking and the unlocking, unlocking is, that is the initial stage of flexion, is caused by the action of popliteus muscle. So muscles producing movements, extension, what are the muscles causing the extension of the knee joint? So in the lower limb, the front of thigh muscles, they are the extensors. So what are the front of thigh muscles? Quadriceps femoris. Flexion, that is the back of thigh muscles, hamstrings, initiated by the popliteals and assisted by gracilis and sartorius, also by the both heads of gastrocnemius and the plantaris. Medial rotation, semimembranosus, semitendinosus, popliteus, sartorius and gracilis. Lateral rotation by the biceps femoris muscle. Relations of knee joint. In front, you can palpate the knee joint. So it is total contrast to the hip joint, where you cannot palpate the hip joint. Knee joint we can palpate. In front it is only the quadriceps femoris. You can palpate the patella, ligamentum patallae. Anteromedially, medial patellar retinaculum. Anterolaterally, lateral patellar retinaculum. Posteromedially, that is the three muscles, gracilis, semitembranosus, semitendinosus and sartorius. They are going for insertion to the upper part of medial surface of tibia. Posterolaterally, tendon of biceps femoris and common peroneal nerve. Behind, popliteal vessels and tibial nerve. So these are the relations. So this is in front quadriceps femoris, laterally and medially patellar retinacula. Then posteromedially this three tendons, pes anserinus. Posterolaterally we have this biceps femoris. So bursa, again, if you see knee joint, everything is 10 or 12 in number. We have seen ligaments, so many ligaments. Now bursa, if you see, in front 4, on sides 4. In front 4 bursa, subcutaneous prepatellar, subcutaneous infrapatellar, deep infrapatellar and suprapatellar bursa. So these are the 4 bursa. Suprapatellar bursa, you should appreciate, it extends in front of this, it extends above the knee joint in the front of thigh for about 8 to 10 centimeters. So this is an important bursa. If you see and cut in the lower part of the thigh, you should expect whether this suprapatellar bursa is cut and the blood has entered the knee joint. So it should think that this bursa extends above the knee joint up to 8 to 10 centimeters. Laterally 4 bursa and medially 4 bursa. Lateral bursa, bursa deep to lateral head of gastrocnemius, bursa between fibular collateral ligament and biceps femoris. A bursa between fibular collateral ligament and tendon of popliteus. A bursa between the tendon of popliteus and lateral condyle of tibia. So you should know the relations on the lateral side, then you can write the bursa. Medially, a bursa to the deep to the medial head of gastrocnemius. Then in between the 3 tendons, we have seen so many times pes anserinus. Then a bursa deep to the tibial collateral ligament, a bursa deep to the semimembranosus muscle. So these are the so many bursa we have seen. So this is what I was telling, suprapatellar bursa extending in the lower part of the front of the thigh about 8 to 10 centimeters. If we have this cut over this region, then we may expect blood may enter the knee joint. So subcutaneous, this is suprapatellar bursa, subcutaneous prepatellar. So in front of patella. Then infrapatellar are 2 in number. This is subcutaneous and this is deep infrapatellar. So this is what you should learn: housemaid's knee and clergyman's knee. So housemaid's knee is this bursa is inflamed. If this bursa is inflamed, that is called clergyman's knee. So these are the bursa on the lateral side. So this is the bursa on the lateral side, and these are the bursa on the medial side, and these are the bursa on the lateral side. Nerve supply. 10 nerves, 3 from the femoral nerve, 3 nerves to the vasti, 3 vasti muscles, 3 from the tibial nerve, superior and inferior medial genicular nerves and middle genicular nerve, 3 from the common peroneal, they are the superior and inferior lateral genicular nerves and recurrent genicular, 1 from the posterior division of obturator nerve. So 10 nerves. Blood supply, you should know the genicular anastomosis and you should write about the genicular anastomosis in detail. Applied anatomy of knee joint, there are so many applied anatomy of knee joint, surgical anatomy of knee joint. So you should think of injury to the ligaments, injury to the bursa, and then arthritis of knee joint replacement. So many applied anatomy we can tell. That's what we told in the first. In bursa, it is inflammation of the bursa. It may be housemaid's knee or clergyman's knee. What is the difference between these two knee are? So in the clergyman's or the nun's knee, if you kneel on the knee with trunk straight, then this subcutaneous infrapatellar bursa is inflamed. If you kneel on the knee with a trunk bent, then this subcutaneous prepatellar bursa is inflamed. That is housemaid's knee. So that is the difference. Injury to collateral ligaments. So tibial collateral ligament or fibular collateral ligament, mainly in the games. Football, if you expect injury on the medial side or on the lateral side, usually tibial collateral ligament is torn more than the fibular collateral ligament. If the fibular collateral ligament is torn, it will pull the head of the fibula along with it. Even common peroneal nerve may be injured. Injury to menisci, again all these are the sports injuries. Knee joint, as they are very superficial and they are prone to be affected in the sports. Injury to the cruciate ligaments again. So injury to cruciate ligament, if it is one cruciate ligament is torn, then you can expect the knee joint to move front or back. They are called as anterior drawer sign and posterior drawer sign. You should know the patellar reflex in the physiology. Patellar tap is the, if there is a if we expect fluid collection in the knee joint, then we do the put a needle, then that is called patellar tap. Then same like we learnt in the hip joint, coxa valga and coxa varum. So the angle, normal angle between this condyles of femur and tibia, if they are increased and if they are decreased, they are called genu varum and genu valgum. So these are the MRI. So as we have told already in the CBME curriculum, you should know the radiological images of the knee joint and you should learn comparatively with the anatomy of the knee joint. So I have given clearly the numbers. So 1 is lateral menisci in the picture, then 2 is that is the collateral ligament, 3 is head of fibula, 4 is again medial meniscus, 5 is tibial collateral ligament, 6 anterior cruciate ligament, 7 is posterior cruciate. This is the way to read the MRI of the knee joint. Yes, that's what we have telling how this cruciate ligaments are torn in the sports. So you can appreciate in which positions of the knee joint how these ligaments, medial meniscus, and along with the medial meniscus, anterior cruciate ligament is torn. As I was telling, anterior drawer sign, anterior cruciate ligament is drawn, so you can move the knee to the front much. Then posterior cruciate ligament is torn, then that is the posterior drawer side. So in the arthritis, osteoarthritis of the knee joint in the elderly, you should have learned or you should have seen in the elderly persons in your house, knee joint replacement. So these are the metal parts of the knee joint which are replaced in the knee replacement surgeries. And this osteoarthritis of the knee joint is common in the Indian population, where we use the Indian type of the commodes. So summary of knee joint, we have to learn the type of the knee joint, compound and complex, articular surfaces of the knee joint, and various ligaments which are extracapsular and intracapsular, relations of the knee joint, and BURSA are all around the knee joint, and the movements of the knee joint, mechanics of the knee joint, nerve supply of the knee joint, blood supply of the knee joint, and so many applied anatomy of the knee joint we have learned in detail. I think you should have learnt in detail in this video of knee joint, which is an important essay for the first MBA. It's not only important essay, it is an important joint to learn as such. Those who have not subscribed to the channel, do subscribe now, so that you will have the continuation of gross anatomy, histology, embryology, neuroanatomy videos. With the next topic in the lower limb, we will see in the next video. Thank you.